question. This is a good continuation of your presentation. I think we have time for at least one more question. And it says, considering there may be continuous or residual effects or long-term complications from the TTP event, would prolonging the treatment help prevent these sequelae? And I think it's a good chance to comment on, is there a distinction between the acute event and the long-term, and when do these things happen?
Yeah, it's a great question. And I think, what I was trying to highlight too in some of my talk is the trouble is with some of these events is that they're happening during clinical remission. So, I think Dr. Abu Ismail's talk was very well illustrated, kind of how those microthrombi form in the acute setting, and they kind of show how that damage occurs. And most of our treatments for TTP are really, for the acute treatment of TTP, are really focused on preventing those microthrombi from occurring. But when you're seeing, potential complications long term, and there's no microthrombi there to fix, that's the reason that we're not using some of these acute therapies over a long period of time to try to prevent these long-term complications, um, because there's no microthrombi, at least that we're seeing, in our peripheral smears and the other tests that we have to be able to kind of measure if this is happening or not. And so that's why we don't use it, because it's probably not going to really be effective if they're not forming those microclots very actively. Yazin, I don't know if you have thoughts as well.
Yeah, and just one more small thing to add is, it's a really good question in terms of, there are long-term sequelae that are serious and we want to prevent them. And what I would also say is one way to address that is not necessarily extending the treatment, but rather expediting the time to response. So there is interest in or merit in saying that using therapies that are adjunctive that will make the time to recovery faster, meaning there's a
Yeah.
shorter exposure to the microthrombi and their effects, that this could potentially minimize long-term sequelae, but this hasn't been studied in this fashion yet.
And I think we have time for one last question. Maybe I'll just answer it. I'll have some fun here with you guys. And asking about new treatments, Cablivi, recombinant adalimumab, rituximab, prednisone. Have you noticed a lower relapse rate in TTP patients? And I think yes or no is the answer. It's not clear to us if we're preventing with this preemptive approach of treating before you drop your ADAM TF13 activity to prevent a relapse. It's not clear if you are preventing or delaying a relapse of TTP. That's sort of an active question. But certainly by preventing the drop below 20%, you're lowering markedly that risk of recurrence. So a good question. In some, it's preventing permanently. In some, it's delaying. And we just don't know it because most patients prefer the preemptive approach than to being at risk for relapse. And with that, Claire, are we at time here? Do we have to stop?
We are. Can you hear me?
Yes.
Yeah.
Oh, good.